don't do video. I think I haven't done any videos in like the last few months, I think. I don't know, well, it seems very long ago that I did one. Okay, what do we have for today? Okay, it says manage the condition, not the numbers. Low AHI does not mean good sleep. Okay, before I get misquoted, which I always do, okay, let me explain myself. What do I mean by this? Okay, we all know that AHI is the key indicator to determine how severe one's obstructive sleep apnea is. Yeah, so 0 to 5 is normal, 6 to 15 is mild, 16 to 30 is moderate, and above 30 is severe. Yeah, AHI is also used to compare if a patient has improved, right? Post-intervention, be it post-CPAP, be it post-surgery. It is probably the only way to determine if the patient has improved. Yeah, so if before intervention, AHI was like 30, after intervention, AHI was like 3. Yes, ta-da! Well done. Yeah. Okay, but what I'm saying is, should we be relying solely on AHI to determine if patient's sleep is good or not? I personally don't think so. Okay, so take for example, my patient. I actually did an episode on this like a couple of weeks ago. No, a couple of months ago, a couple of episodes ago. Okay, pertaining to an AHI of 0.9, should we increase the pressure or not? So, for those of you who have not watched it, the story goes like this. Patient was under my care for about a year plus, all was good. Given the pressures that I set for her, she's getting an AHI of like 0.7, 0.9. Didn't go beyond 1 from what I remember. But suddenly, one fine day, she called and she sounded so desperate and just like, Michelle, I can't take this anymore. My sleep is so bad. Like, there's something wrong. I don't want to use the machine anymore. And I'm like, wait. Like, why? You should have told me earlier, because she said she's been suffering for like 2 months. So I said, I wouldn't know, because when I look at your summary data, it says that your AHI is 0.9. So you need to tell me if you're feeling horrible. And she said, yes, I've been feeling really horrible. I've been waking up at night, many times at night. I don't know why, I can't get back to sleep. So all in all, I get about 2 hours of sleep a day. And yeah, so I was like, but how can it be, right? I mean, your sleep is supposed to be better now. I mean, it used to be, her AHI, if I'm not wrong, used to be like 70-ish or 90-ish before CPAP. But after CPAP was less than 1. So I dug deeper into her detailed data and realized that, hey, she doesn't have apneas. She has very little hypopneas, but she has a lot of RARAs, right? RARAs are respiratory effort-related arousals. They do not meet the criteria of apneas or hypopneas, but they do cause sleep disruption, they do cause sleep fragmentation as well. So I said, wow, like, this wasn't here previously, and I think she just started with me like a year ago, and she never had that much RARAs. Because if she had that much RARAs, I'd probably have increased her pressure a little bit higher, to manage it. So I asked her, I said, did you put on weight? And she said, yes, a lot. And I'm like, okay, I think that might explain, because usually weight gain can cause a drastic change in your AHI or your quality of sleep. So what I did was, I said, okay, let's try this. I increased the pressure further, just by I think just 1 or 2 more cmH2O. And it was fantastic, it was good. The next day she called and she said, oh, it's good again, I slept well, thank you so much. So back to my question. Can we rely on AHI? Or can we solely rely on AHI to insist that the patient is having good sleep? Yeah, another patient called in desperation, and he was like, please help me, please help me. I was like, why? He said, I've been having such bad sleep and no one would believe me, no one would help me. And I was like, no, can't be. Like, why would anyone help you, right? Why would anyone help you? Why would anyone, attend to you? And he said, I went back to my vendor, I went back to my doctor, and they said that my AHI is 1.5, so there's no reason why I'm not sleeping well. And well, he said that they basically told him to get used to it, live with it, and that his sleep is already very good. I was like, no, but honestly, how do you actually force someone to say that their sleep quality is good? I wouldn't. I think sleep quality or how restful you feel is really subjective. It's like pain, right? I feel that it's not painful, but you can feel like it's terribly painful when it's the same amount of pressure, like someone pinches you with the same amount of pressure. I can feel that it's not painful. You can feel it's very painful, right? Or injection, yeah. I mean, some people can feel that the same injection is very painful, and others can feel that well, it's just an ant bite, or I couldn't feel a thing. So I think sleep is very similar. So how do you actually force it upon the patient and insist that the patient had good sleep when he said that he didn't? Okay, so what I think should have been done, or what we usually do, or how we manage such patients, firstly, firstly, of course, to go into detailed data, if we have access to it, to see if it's because of things like RARAs. Okay, so the good thing is the ResMed Essence 10 order set for her actually has RARAs reporting, so that helps a lot. For patients who are on other machines, yes, I would lend them the Essence 10 order set for her just to see if we can capture any RARAs along the way, and to see if that is why, despite the low AHI, patient is having very, very bad sleep, very fragmented sleep. Yeah, sometimes it might just be stress. Patient is very disturbed. Patient is not even able to go to deep sleep, so patient is waking up, and it kind of ties in, right? Because patient is not having good sleep, he's not going into deep sleep, so his AHI looks beautiful, right? It's just like if I stay awake for the whole night with a CPAP on my face, my AHI is probably like 0. Stress is one of the other main contributors, I think, of bad sleep, at least among some of my patients. So sometimes I have to sit down and help them to identify stresses that they are facing. I have to help them to identify recent stresses and stresses that could be affecting their sleep, or stresses which can be resolved and how they can resolve it in order to get better sleep. So I do things like that. Okay, so besides stress, for some of my patients, diet actually plays a very, very big part as well. One would have fragmented sleep or a lot of sleep disturbances if he eats too much. If he eats beyond what he usually eats. Not sure why, but he's tried, tested, and yes, it happens when he eats too much. The other patient has multiple awakenings at night if he takes something which is with high salt content. Tried and tested as well on days that he took his mala hogua, and on another day that he took his some Italian food that was very salty, he told me. Or rather, I don't know whether it was salty, but according to him, it was salty. He kept waking up throughout the whole night. So I think some studies have shown that salt intake actually affects sleep quality. So because there's so many factors that actually affect how restful one's sleep is, or how well someone has slept, I don't think it's fair for us to insist that the patient had good sleep and tell the patient, no, your sleep was good. Your sleep couldn't have been bad because your AHI was less than 1. I think it's not very fair to the patient. Yeah. I mean, okay, but to be honest, there are some patients that the ones that have hypochondriac tendencies, right? Sometimes every little bit of thing, for example, they woke up 5-10 minutes earlier than usual, and they would start feeling that, oh, my sleep is bad, or if she took maybe 5 minutes, 10 minutes longer to fall asleep, that, oh, my sleep is bad. Yes, there are patients like that as well. But what I'm saying is there are a lot more patients out there that need us to go deeper into their detailed data, into their lifestyle, into their habits, to see what can be contributing to their fragmented sleep or their lack of restful sleep. Yeah, so that is what I mean by manage the condition, right? Because patients having bad sleep. But if we keep looking at the AHI, we will insist that no, you are having good sleep. But who are we to insist that? The patient's the one that's going through the sleep, not us. So how can we tell the patient, no, your sleep was good. Come on, your AHI 0.9, your sleep was good, so tell me it was bad. Yeah, so I think we need to go deeper into it. Sleep diaries help. If we need to refer to our other collaborating doctors, like our psychiatrist, our collaborating psychiatrist, Dr. Wong Xiaohua, or anything else, the pain doctor, Dr. To. I think we need to do that. Yeah, if let's say pain is actually keeping the patient up, or let's say if the patient is depressed or things like that. And I think only if we have exhausted all channels and nobody can find anything wrong with the patient, then maybe we can try to help the patient find a way around it. But we shouldn't keep dismissing what the patient says, and the patient says that they have bad sleep, and you shouldn't keep insisting that no, you didn't, you had good sleep because your AHI was low. Yeah, that's all for now. Bye.